Okay. Well, hello everyone. Welcome to our webinar today. We're really excited to have you all here with us and to have a guest presenter here to talk to us today about creating a workplace violence safety committee and to cover a tactical guide for home and community-based providers. Jonas is here to deliver this information to us from Palm Safe. Before I turn it over to him, I just want to cover a few logistical items. In the chat, you will find a link to the slides. I've also launched a poll that I'm hoping you all can participate with so that Jonas has that information. This is being recorded, and a copy of the recording will be a copy of access to the recording will be emailed out to everyone who's registered for this event, including all of you who are in attendance today, so that you can share this information with your staff or others in your office. After we have completed the interaction with the poll, I will be turning the chat off, and I will ask you all to use the Q&A tab to post your questions. And at the end of our session today, hopefully we'll have some time to go over a few of your questions. So please use that for any questions related to the content or related to information about today's webinar. And with that, I'd like to turn it over to Jonas to introduce himself and get us going.
Thanks so much, Denise. Hi, everybody. I'm Jonas Fortenberry. I'm the VP of Business Development here at Palm Safe. And I'll give a little bit more background about myself and how I came to this space and why I'm speaking to you guys today. But first, want to just go over a little bit of the session objectives and appreciate everybody answering the poll as we get in here, just to give myself a better idea of people that may be coming in and looking to optimize their safety committee if they have one, or if you haven't started one, that's fine too. Just to kind of inform some of the things I talk about as we go through the slides. So first, let's start with kind of the objectives here in the hour that we've got time, and we will leave some time to questions at the end. If you put those in the Q&A, we'd love to answer or hear any feedback you have just on things that you've got going on if you do have a safety committee, or questions you have if you don't to get started. So first, we're going to talk about understanding the role of a workplace violence safety committee, the definition of and types of workplace violence, kind of the case for building a workplace violence safety committee beyond regulations and compliance, but what it does in terms of fostering a culture of safety, how to develop an effective committee structure, so where to start if you haven't started, or some things to think about in terms of roles and responsibilities with the committee if you do have one but are looking to kind of expand its impact. And then we'll talk about kind of implementing certain proactive safety strategies as part of that. So what do you do with a workplace violence safety committee, and then what are the outputs that come from that, based on taking information in, and what can you use the committee to do to strengthen again that culture of safety. So I'm going to jump forward here and kind of give a little bit of background about myself. So who am I? How did I get up here in front of you all? I went to 9 schools in 12 years growing up, so moved around a ton as a kid. And I was always kind of the why person, asking questions about everything, as we moved to different states and different areas. That continued as I kind of got into the workforce. I was actually in advertising for the better part of 15 years in marketing advertising, making commercials. I kind of fell into healthcare with a business partner of mine who was in the senior living space, and he and his wife bought a Medicare number. They wanted to move into the helping side of things and create an agency. So he asked me to join and partner with them in doing advertising and marketing in this home health and hospice agency that they bought. So again, me asking why and wanting to understand things better, jumped into this world of home health care and hospice, and we had a non-medical care line as well. I quickly realized that we didn't necessarily need as much help in the sales and marketing side of things as we needed to understand what and how to better take care of the patients once we got them kind of in the door and once we created those relationships. That led to me, diving into COPs and asking the questions of why do we do it this way? And the major answer I got most of the time was, well, that's the regulation, or that's the way we've always done it. And so I went down this path of understanding really the world of home health and hospice and how that works, and become an administrator on that side of things. So I was an administrator a number of years in Akron, Ohio. That's what that picture is there. And really thought as part of that, we were really building a culture of safety, digging into the whys and making sure patients were taken care of and that everything was, working well and kind of a well-oiled machine on that side of things from a non-skilled or non-care perspective, because I don't have, again, that healthcare background. What I didn't realize was that I wasn't answering all the questions, and kind of drove me to where I am now. This is a picture of downtown Akron, Ohio on the screen here. And I remember specifically a time we were out with a handful of nurses and social workers and doing a happy hour downtown. And one of the nurses pointed to a high-rise building, catty corner to where we were, and mentioned how that building always creeped her out. And she really never wanted to go in there. And it was the first time now looking back on it that I didn't ask why. My response was, that's too bad, or that's tough. But we're taking care of the patient, and we're taking care of the patient, right? It wasn't digging deeper to understand when we talk about safety, it's not just, about patients. It's not just about PPE, on a caregiver. It's the things that make them feel, safe when they're out there doing their job. In our office, people couldn't get in the door without buzzing in. We had to understand why they were there, and what they were doing before we let them in the door of the office. Caregivers that go into home don't have that choice. They're finding out what's behind door number one every time they go into a house, each time, and not just the first time, what's standing behind it. So I think back on that story to where I am now. Moved into the healthcare technology space a number of years ago, and now I've been at Palm for 3 years, and really focus and put passion into that side of things. When we talk about a culture of safety, yes, of course, patients are part of that. But it's growing. We talk about workplace violence and the things that can happen, and quite often it's not the actual act of violence or what you think that definition of violence might be, which is something physical outward that happens. It's the other things that you can't see, those soft acts of violence. So we're going to dig into that now a little bit and talk about kind of the definition of workplace violence. So OSHA and the National Institute of Occupational Safety and Health define violence as any act or threat of physical violence, harassment, intimidation, or other threatening behavior that occurs at the workplace. And again, the workplace for most people is an office building, or oftentimes now working from home like I do. But the workplace for our caregivers are anywhere that's in the community. And so it's different every day. It's different every visit. And so those workplace violence acts, using the word violence, I think a lot of people think of, again, that physical act, but more often than not, it's those threats, it's those harassments, it's those threats of physical or verbal abuse, bullying, which might always not be physical. And it's not necessarily just the patient, it's the people that are around that. It can be people in the home, it can be people in the neighborhood. And so OSHA further defines that of what are these different types of workplace violence. And there's 4 different types. Criminal intent. This is where someone has no real legitimate relationship to the business or the employees. So it's usually committing a crime like robbery or shoplifting or trespassing. Example in home health or community care would be a nurse assaulted in a parking garage or parking lot, or home health care nurse mugged while conducting a visit. This type of violence actually occurs less frequently compared to the other types of violence in home care. But it is still one that people need to be aware of when we talk about not just the nature of the home, but the community and the area you're going into. Type 2, this is the most common in healthcare settings. And this is considering a relationship of customer-client, which includes patients, family members, visitors, and you'll often hear it referred to as client on worker violence. So this is the one that's the most common. Worker on worker, we're all familiar with. Type 3, this is commonly referred to as lateral or horizontal violence. It includes bullying, and usually manifests itself as a verbal or an emotional abuse. And again, not just happening in the workplace in an office, but when we have a group of people that are working in a community, something to be aware of. Again, when we talk about creating a program, it's not necessarily just patients, it's potential worker on worker. And the 4th one is a personal relationship. So this is where they have a relationship to the caregiver outside of work that might spill over to the work environment. For example, a nurse may have a spouse that follows him or her to work, maybe orders them to come home or threatens them with implications. And this is dangerous not only for that caregiver or nurse, but the coworkers and patients. We actually had this come up recently with an agency we work with, where a caregiver was not able to be gotten a hold of. And they didn't know where she was, couldn't get a hold of her via the phone. And so we're working to find out what other mechanisms do we have, within Palm that we could find out what's going on. And it wasn't something, again, that was that type 1, 2, or 3. It was type 4 that she had kind of gone off the grid because, her spouse had come to her workplace, again, the community, and kind of jarred with her day. And so they were able to find her and sort that and work that. But again, that is one that's very common too. And when we talk about creating a committee, that's something we want to make sure to cover as well. So a full definition of workplace violence, act or threat occurring at the workplace that can include, again, very important, verbal, nonverbal, written, including the physical aggression. So harassment, humiliating words, bullying, sexual harassment, all of those, and again, that involve staff or practitioners, patients, or visitors. Now, as we move forward and we talk about, again, what's the case for creating a committee, state legislatures have been very active in this. And I've put a list up here of states that have active or pending legislation around workplace violence. And these are ones that are specific to healthcare, either facilities or practices. Many other states have workplace violence laws. And then OSHA obviously has its general duty clause, which allows to provide for violence and safe work environment. But within these state legislation ordinances, there's certain key themes, and most of them have some capacity of one of these three themes. Implement risk assessments. We're going to talk about these. Creating an actual violence prevention plan that's documented for your organization, and then training that's provided to protect employees from workplace violence. Beyond state legislation, there's been congressional movement at the federal level. On April 1st, there has been legislation that's started and stopped over multiple years, but on April 1st of this year, the Workplace Violence Prevention Act, specifically for healthcare and social services, was reintroduced in Congress and is currently in committee. So again, it's something that's going to continue to be brought up, and unfortunately, sometimes these get pushed forward when there's something that actually happens, and we hate to see that, and we want folks to be more proactive and not wait on something like this, but to be ahead of that curve in terms of violence. The Workplace Violence Prevention for Healthcare and Social Services Worker Act specifically directs OSHA to issue a federal safety standard for workplace violence prevention. So going back to that state legislatures notes some of those key themes, and the things that are required are going to be like a workplace violence prevention plan, annual risk assessments, and talking about violent incident investigations and how you log those, training for all staff, specific and documented incident response procedures and protocols within a building or facility, things that you do in terms of engineering and work practice controls, and then record keeping. Again, mentioned those annual evaluations, but response to those, what the record is, and how to report that to OSHA and to Congress. And then any anti-retaliation protections for staff who report concerns. So that's kind of the legislative side of things. But practically, why would we need a workplace violence safety committee? I want to talk about some numbers and the extent of the problem. So I'm going to put a number up on the board. We obviously don't have kind of the interactive capacity here in terms of people shouting out answers that we might in a room, but just want you to think about these things and these numbers and see if you can kind of tie them to, what you may think this number, represents. So the first one is 96.1%. So kind of think to yourself what this may cover and what the stat might align to. So the answer here is 96.1% of healthcare professionals have experienced verbal abuse or intimidation in the workplace. Again, specific to healthcare. That's almost everybody. And again, we talk about violence. It's paramount importance to not just think about the physical side of things, but the things that really can impact care in the home. And we'll talk about that in a number here you see in a minute. 47% is the next number. This talks about reporting incidents. So only 47% of nurses report incidents to their employers. And the number one reason is perceived lack of action from management. If staff don't see action, they stop speaking up. And that silence puts everyone to risk. Going back to my introduction, I was to blame at my agency for this. Talking about inaction, my thought process was not primarily on my caregiver. It was the patient safety, patient safety, patient safety. But behind that 53% number of unreported events, there's warning signs. And these are flags, red flags, yellow flags that never make it to leadership. And a safety committee is something that can help rebuild that trust by creating follow-up processes, proactive processes, and closing the loop with staff to make them feel safe to be able to report something. And we're going to talk a little bit about that later, specifically what we call near misses. All right, last number, and then we'll dig into kind of components of a committee. 20%. This number ties to what we're talking about in terms of productivity, and quite often caregivers going into the home are everything. They're the caregiver, they're the security agent, they are sometimes housekeeper in that sense too. 20% is the number of workers exposed to violence experience a 20% drop in productivity, and that impacts team performance and ultimately patient care, which is the number one priority. So even if an incident doesn't result in physical harm, that emotional toll sticks. We talk about things like fear and anxiety, even more important, distraction. It reduces focus and efficiency. Most importantly, in home-based and community care, where staff, like I mentioned, are already working independently. So when you talk a 20% drop in productivity, that might mean delayed visits, incomplete documentation, missed clinical cues, which can lead to things like medication management, something within documentation, and all of those things directly affect patient outcomes. And unsafe environments in those situations undermine that care quality. So when a worker feels unsafe, they might spend less time engaging meaningfully with patients, and more time thinking about how to protect themselves. You don't have the benefit of a hospital that has a metal detector and a security staff and cameras and all those things. And so when you're primarily thinking about your safety or what could go wrong, you can't deliver that compassionate, attentive care because you're scanning for exits or texting a colleague to say, hey, give me a call. I'm feeling unsure. And then it spreads. We talk about that, one violent or threatening incident doesn't just impact the caregiver involved. It talks about impacting the whole team. Your staff talks to each other. Morale drops. Turnover increases. And at a time in an industry where recruitment and retention are of paramount importance, this is one thing that can impact, and it's something that we can impact in terms of a positive nature. So safety committees can break that cycle. And the things that does is let you address threats early, offer support to your staff, again, that culture of safety, and showing them that they're not alone. So let's pull that all together. Let's tie that up in a bow and talk about the case for a committee. So a safety committee exists to challenge the norms. Those numbers we talked about just now, is creating new expectations and making it clear that safety is not a trade-off, it's a right. We want to go from people thinking that it's just part of the job. That was what I was guilty of, and I still feel guilty of to this day. It's not. When you don't have existing policies, or you have poor policies or ad hoc policies and procedures, that's another case for instituting a committee. If you have complex reporting procedures, think about documentation and how we've moved from paper to electronic documentation and streamlining that as much as we can to take time away from documenting and actually focus care on the patient. Think about it in that same way in terms of reporting an incident or reporting the threat potentially of an incident. If you have no process or you have a very complex process, you're actually detracting someone from giving that information, but it can help everyone else on the team. There's the thought that it's going to reflect poorly on the caregiver. I can't take care of myself, or the patient's not going to be taken care of. And then the last one, hey, listen, they can't be held accountable. The patient, has got to be seen. The patient has dementia or the family's under stress. There's a belief that nothing can be done. And these barriers are exactly why a committee is essential. And it's not about responding to violence, but it's dismantling those reasons that a threat or, like I said, a near miss gets ignored. So why do safety committees matter in that sense? It's going to reduce risk and liability. It promotes that culture of safety, and it supports recruitment and retention. There's a number of other reasons, but these are three key ones. Workplace violence incidents aren't just, tragic, they're very costly, and committees help identify patterns, close gaps, and then also prevent harm before it happens. We'll talk a lot about proactiveness. It demonstrates due diligence, which is completely, important and increasingly important with new OSHA guidance, accreditation standards, state regulations that we mentioned earlier. It promotes that culture of safety. So when safety becomes part of a routine conversation, it stops being reactive and becomes more of a proactive thought. It gives staff a platform to be heard. Most importantly, identify concerns and then co-create solutions. All about building trust and showing that your organization is serious about protecting its people, not just the patients, but the people that provide care for the patients, and not just checking boxes. People want to feel safe doing their jobs. So if you highlight safety efforts, including having a dedicated committee, you stand out in a competitive hiring market. Safety is a differentiator. It builds loyalty, can help reduce burnout, and increases likelihood that staff will stay. So what are some of the key functions of a safety committee? These things are the backbone of the committee. And we want to talk about how each of these contribute to a safer work environment. So risk assessment is number one, and we're going to talk about that from intake to discharge, assessing risk at every step of the way. Before you can fix risk, you have to be able to see it, and that's what the assessment does. Committee's job is to proactively identify and evaluate safety risks and not just react after something happens. I'll ask you now to think about Do you have something as part of your intake process beyond just the clinical documentation you may get from the referrer that looks into the safety of a patient, an address, a location? So if you don't do that, that's something you're going to want to include, and we're going to talk about doing that because you want to review incident data, including historical incidents that maybe a patient has had in facility or on a previous episode, near misses, high risk zones, and then patterns, even patterns. And patterns can be something in scheduling or staffing that contribute to potential unsafe conditions. Second key function is policy development. So policies are your guardrails. And we're going to talk about part of the people that are on a committee, the policy of the guardrails, and they should be built by people who use the road. And so in a minute, we're going to talk about those types of people that should be on a committee in a kind of a multidisciplinary approach. Safety committee helps write and revise policies, make them practical, understandable, enforceable, and keep the staff informed. So those types of things include escalation protocols, what your home visit refusal policies might be, and expectations around follow-up and reporting. Third is incident response. So what happens after an incident? Everything that happens after an incident says everything about your culture. So the committee is going to help ensure that there's clear, timely, and supportive process for responding to threats and those near misses. So those include everything from debrief protocols to staff and safety reassessments. So we talk about the risk assessment up front and doing a reassessment during, and then staff support services when and if an event does occur. And then the last and very important is that safety, that education and communication on safety. And it's not a one and done investment. It's not something you do just at onboarding. It's ongoing, it's visible, and it's relevant. And the committee leads those education efforts, and that's a key component of the committee, keeping safety top of mind with updates, refreshers, and staff input sessions. We had an agency I visited back at the beginning of the year. They started what they call, I don't remember exactly what it called, but kind of a safety huddle, I think they called them. But basically, as a monthly part of their nurses meeting, they have a specific time that's called safety huddle where they share anything that they have either seen or something that they've tried or that they've done to help de-escalate situations, to share it with each other. And if that's communicated there, is it something that's important enough to make it to the safety committee to roll out to everyone? So again, part of the education and communication. Communicating back to staff, hearing those things and what's being done is really important to close the loop and build that trust. Okay, so we talked about the key functions of the safety committee. How do you build your committee? Let's talk about that. You want to include a multidisciplinary staff. And this can start with a committee you might kind of already have. Think of your QAPI team, an IDG or IDT team, but you want a kind of multidisciplinary approach. You want staff from clinical, human resources, obviously the field, and operations. But the number one place this has to start is leadership buy-in. If you're a leader in your agency, you kind of fully endorse this. It's not a group of people in a room. This is a team with a mission, and every team, needs a definition and needs kind of that leadership endorsement to succeed. You need to define roles clearly. Without clear responsibilities, things may fall through the cracks, follow-up doesn't happen, and staff lose faith. And they need a regular meeting cadence. So whether it's, certain, states and regulations have that, how often they need to be done, whether it's weekly, monthly, or quarterly. There are some states, I should say this, that actually provide a rebate on your workers' comp premiums if you have a safety committee, have regular meetings, and have documentation of processes. So again, another reason to have a committee. So let's build that committee. Let's talk about some of those key roles. Again, leadership buy-in, number one. Chair or facilitator, so who's going to guide the meeting, who's going to be kind of ensuring the accountability, who's going to be kind of the leader of the data to bring those incident trends and reports and capturing those. At least one field staff rep to bring in those real-world insights, and then someone in charge of training. So these, there's multiple roles, but these are some of those key roles that you might want to have as part of your committee. Okay, now that we've made a case for why a committee is essential, who's a part of it, let's talk about what it actually does. Again, not checking a box. A committee is really the engine that drives how your organization understands risks, responds to incidents, and protects your people every day. So your committee is kind of like this central nervous system of safety. It senses what's happening, it coordinates response, helps the organization learn and adapt. So over these next few slides, we're going to walk through some of the core functions your committee should own, from shaping policies, reviewing incidents, guiding training, and measuring impact. So real tools to move safety from talk to action. And again, this is something that you don't have to get all right at day one. What matters most is that your committee has that initial structure, purpose, and that endorsement to begin the power to influence real change within your organization. So number one, policy development. Policies really set the tone for safety. And first is to create a zero tolerance policy. Your policy should make it clear that violence, threats, and abuse, physical or verbal, will not be tolerated. A strong zero tolerance message, and statement sends that message to staff, patients, and families that safety is a shared expectation. It also gives the staff permission to speak up and walk away when something feels unsafe. They know leadership backs them up. We had an agency I visited in Mississippi that was telling the story of a visit, and they were feeling a little increasingly uncomfortable, not with a patient. There was a family member in the home that was kind of pacing, clearly kind of agitated, wasn't sure if it was around the care being given, just someone, unknown being in the home. But the nurse, he had permission to walk away. And so he said, maybe we just need to do this visit another time. I'm going to reschedule it. Gave himself an excuse to walk out and leave the visit. Communicated this back to his team. They did kind of a reassessment, followed up to reschedule that appointment, and found out that family member had actually gotten arrested that night because they had left the house, got into an altercation with someone in the yard, and was arrested. And so who knows what would have happened if that nurse, didn't have permission to walk away, excuse himself from a situation when they felt unsafe. So they went back and did the visit later that week. But again, we talk about a near miss. The near miss is just as important to capture and understand that there's something, to look for in the home beyond that reactiveness of something, actually kind of happening. Similar to that, response protocol. So the moment a safety incident happens, it's not the time to figure out what to do. You should already have a plan that exists. And this is one. They have that, understanding that they are able to walk away. They're able to make a phone call or a fake phone call, which is an opportunity for someone to de-escalate and pop out of a situation. There should be clear step-by-step processes for how to report when we talk about the response protocol. So how to report, respond, and follow up to these incidences or near misses. And then guidance on when to notify leadership, if and when to involve law enforcement. And then as part of a patient handbook, when to consider discharge for cause if a patient or household poses an ongoing threat. Safety is part of that care contract, and the patient and the family and people in that, the location need to understand that from day one. So in that patient handbook, you should include language, under the rights and responsibilities about respectful behavior and what happens if staff are threatened. This also, again, helps protect your agency from liability, and it supports staff when difficult decisions need to be made. Again, giving that permission allows them to de-escalate or to walk away from a situation, and gives them that permission. I'll ask you again, just kind of thinking on your own as we drive forward here. And if you want to raise your hand, if you're able to do that or hit the react button, do you at your agency know, or do you think your staff knows what to do if they're threatened? Do they know step by step what to happen, what to do if they're threatened during a visit? And then second, do you guys have, a zero tolerance policy for workplace violence yet? Great. Okay, let's talk about starting, with risk assessments and understanding risk. Again, these incident reports are data. And when I talk about incident reports, I'm going to mention again the near misses. It's not something that ultimately happens. It's that feeling. How many times have you, if you are in the field, or if you've ever been in the field, go up to that home or go up to that building for the first time, like my caregiver did, and just have that uneasy feeling. And how do you report that? That's data to use. That helps you spot trends. So you can start with data you already have. If you have field staff feedback, if you have HR logs, if you have notes in the EHR that you can pull out and use to log, that's what you want to do. Those incident reports, again, are your data. You can use OSHA and other tools. So I talked again about at intake. There's a workplace violence prevention list that OSHA has. There's other guidance to help you kind of standardize how you identify and score risk. Some of the state legislation, has requirements that you need to do a kind of risk assessment at intake to understand the home you may be going into. And that's doing things like, location, name, address checks. You want to be careful. We're not doing full background checks on people, but looking at an address. looking at that discharge paperwork to see if there's history there, doing a high level social media and just kind of Google like search, if you will. And those are kind of ad hoc solutions that exist out there. There are other things that you can do. There's softwares that will help pull some of those things together. You want to map high risk areas and roles. So, are certain zip codes seeing more threats? Are evening visits or hospice admissions showing higher risk? We had an organization that didn't think that they had any problems or had any issues because they were a hospice organization. And then we started asking the question, how many visits, do you go to at night when you're, calling a death, or at the end of life, it doesn't happen, at 2 p.m. in the afternoon. How many times do you go into a house and the family agrees on whether or not mom, dad, aunt, or uncle should be on hospice? Is there tension there? And they started to understand that there was more high risk in some of those instances before, and built some protocols into those times. Are certain roles, think aides, LPNs, on-call nurses, are they disproportionately affected in terms of incidences or those near misses or risks when they're going to home, and there's something we want to add to a protocol there? Once you pull all those together and kind of map that out, use that info to tailor your safety protocols, maybe adjust scheduling or implement technology solutions in those hotspots you can do in terms of safety softwares and things like that. Okay, building controls and prevention strategies. So again, thinking of technology and things that you can do in the field. We talk about mobile safety tools and some emergency dispatch processes. Everyone has tablets, everyone has phones. The best safety plan you can have is one where your team can access in real time wherever they are. So think about mobile connected safety tools like GPS enabled apps or devices that give your staff that kind of lifeline to help when they're working alone. Again, that peace of mind of feeling that they've got some support there because they're not in a building with cameras, security, metal detectors, and all those things, and building those tools in to help your agency respond faster, document alerts. So how can they document, or how can they report something? Think like ways for nurses and for caregivers. What's that way that they can quickly communicate something from the field, so that if I'm the start of care nurse going in and notice something, again, that kind of near miss, something that's just not right, or someone new in the home. We talk about drugs, we talk about hoarding, we talk about a number of things in terms of environments in the home. How can they communicate that so that the therapist that goes in 2 days later has an understanding of that before they go in, versus starting new for the first time? Staff check-in and out protocols. And this is not EVV. This is not Big Brother checking in on you. This is a tool to understand, again, thinking about that data before, if there's a high-risk area, if there's a high-risk time of day, if there's a high-risk type of patient in an area, do you have some kind of check-in and check-out protocol that allows the office to be alerted, or a dispatch company to be alerted if someone doesn't quote say I'm okay? A lot of times we have organizations that will start a process that basically says if it's a high risk patient, if it's a new patient, or if I just have that uneasy feeling, I kind of click a check-in. And if you don't hear from me, check on me. So what are the things that you can do, again, to proactively give that sense of understanding that someone is watching out for them when someone can't be there, and you can't have multiple people taking care of the visits? Um, having that structure really helps understand, and helps you understand, again, is everyone okay? And two, is there something we need to note? How did you feel in the home? How did you feel in the neighborhood? Is it something we need to communicate out to someone else? And then again, there's simple things like, is it parking on the street? Is it somewhere in the driveway? Are there lights out? Is there a difficult way to get into the home? How can you understand and communicate those things to the entire care team? Again, it's not like an office where you can add more lights or you can add signage, but what is that virtual signage or that electronic signage that the care team can be communicated with, so that people that go in at different times of day or different days of the week have that information at hand? Training and education. This is a core part of your prevention program. Simple things like body language, identifying exits, talking in calm tones, when to leave a visit. Having training around de-escalation tactics is really important, and that can be. There's a lot out there. There's a lot of resources out there that you can utilize, even right down to dementia patients versus bipolar patients, and those things in terms of how to talk and understand. I'll do again here if you want to hit the raise your hand button if your team has received any formal de-escalation training in the last year. That's great. It's a regular part of this. And again, there's a number of resources out there. One of the tough things specifically about home-based and community care is if you do a Google search a lot on healthcare violence, you're going to see a lot of training, a lot of information out there about facilities, and less so out there about what to do, kind of in the home. So we provide links to tip sheets, and there are a number of tip sheets out there if you can do a more particular search specifically for post-acute and home health care. There's a lot of resources out there to do that, and we'll provide you some here as well. All right, going back to that leadership visibility and fostering an overall culture of safety. Like I said at the beginning, culture starts at the top. If your leadership isn't showing up to talk about safety, no one else will either. We have an agency that we work with in the Northeast that has their leaders do a safety ride along once a month. They go out of the office and they do a visit with the caregivers to just kind of understand and listen what's going on in the field. Another one that makes it part of their effort to kick off training sessions with the leader being there and kind of sitting in on it. Simply attending a committee meeting sends a big message, I should say. A small moment just to be there, sends a big message that safety matters here. Visibility isn't kind of micromanaging. It's really modeling the behavior that you want others to prioritize. The other is celebrate reporting. A group that we talk to that really is part of their, again, monthly meeting, they give kudos out to someone that reported something, again, thinking of that near miss, encouraging them to report those near misses or risky environments. And they give us what they call a safety spotlight award out, and a shout out in a team meeting for that. You got to move from the way I reacted, which is that's tough or that's too bad, to you're tough or you're brave for reporting those things, because again, being proactive in that sense of something that may happen and letting others know to be more careful about it should be recognized and not questioned or minimized. All right, so we've got the committee. We've talked about leadership down. We've talked about different components of committee and things to think about as part of that. How do we kind of measure? What do we do with that? Metrics and accountability. So tracking the performance really helps the committee refine your policies and show that impact. We've an agency that created a dashboard for themselves to track things. We met with them, and they told me that they had 0 incidents in the past 6 months. And then I asked about near misses, and they kind of shyly said, "What are you talking about, near misses?" I said, "What about those things that weren't an actual incident, something that actually happened, but that feeling of there was someone else in the home, there was some environmental thing there, whether it was even an aggressive dog or just someone kind of out of place." And so they took that back to the committee to talk about what do we do with that? How do we implement that in terms of people being able to report those things to us? And when we talked to them a handful of months later, they had increased their incidents 60%. And that was a good thing. Again, not incidents in terms of something violent happening, but in terms of reporting and getting that data back to be able to understand trends, whether it was visit, whether it was environmental, whether it was neighborhood, all of those things that they were able to use that data to say, are there protocols we need to place in certain areas, from a check-in procedure to just communicating to other staff members to something to be aware of before they actually go into the home as well. A culture of safety is not about tracking what went wrong. It tracks what almost went wrong or could have gone wrong. Think of it as an early warning system for bigger issues and providing that data that gives those patterns, risk areas, unsafe practices. If you had to pause or think about something in a home, or you had to, the example earlier, leave a home early, that's something worth logging to track and understand. And really, it's again back to that fostering a safety culture, a no blame, low barrier, reason and way to report these things. Even a 2-question digital form at the beginning or end of a day of how did you feel in your homes? How did you feel in the area? Going back to the office and being able to ask, is there something you want to report? Is there something we need to take a look at? Staff surveys are really important. The easiest way to understand how safe your team feels is to ask them. We talk about anonymous pulse surveys that some agencies do to uncover kind of those hidden risks or staff concerns. One agency just does 2 questions. They said, have you ever felt unsafe during a visit in the past 3 months? And do you know how to report a safety concern? And that goes out to their team every quarter. And so that they can get those answers, and that it can allow leadership to communicate back that they take those things seriously in terms of reporting. And then monthly review of incidents. Again, this is something your committee can do in terms of tracking metrics and kind of fostering that that feeling of accountability, because metrics don't matter unless they drive action. We talked about location, time of day, visit types, those things to understand the data that you're getting and seeing. Again, just simply asking maybe a couple questions as part of a day or a week so that you can adjust some of those protocols. And then if you have or can build or use a software to have kind of a safety dashboard at your monthly meeting to kind of keep, again, safety top of mind, to understand how many people might have answered some questions, how were people feeling over the course of an episode or their month in terms of feeling, safety or something that they want to report, so that you can, keep safety top of mind and not just check a box for compliance, but really understand that you're listening. Because what gets measured gets managed, and what gets shared gets improved. All right, so some common pitfalls. One of the biggest missteps a committee makes is one that's made entirely of administrators, so people in the office, and no one really representing people actually walking into the patient homes. Field staff really offers those critical insights into those real-world safety concerns that leadership, might not never hear. And if their voice is missing, your solution is going to really miss the mark. So you've got to include that to be more effective. Ignored reports. So again, we talk about what's the process to report, what happens after that. So if someone takes the time to report a concern and they don't hear anything back, it really sends a message that this isn't a priority. And over time, that silence really erodes that trust. And then you're only going to hear about something when it gets escalated or when someone gets hurt. So again, you want to make sure that when someone has an understanding of what and how to report something, that they get some feedback back in terms of what's being done about it. And the committee's function is that they review those reports, they follow up and share outcomes, and really visibly act on those staff inputs. And then lack of follow through. If someone keeps raising, or a team keeps raising the same concerns and nothing changes, that's not a problem with your policy. That's a problem with your credibility. And you need to execute on that. So even small wins like a policy update or a piloting a new safety kind of function or process really shows that the work matters and the staff voices are heard. And this is going to be a theme here as we get to the end. You don't really need to be perfect. It's really getting started and doing something so that your team can see and feel a difference being made. All right, we're getting close to 15 minutes, and so I want to leave some time for questions. But I also want to give you kind of some next steps here, again, of somewhere to get started. Whether you already have a safety committee and are really just kind of looking to optimize some things, or whether you're getting started. We've made the case kind of why a committee is essential, and what it does. It's beyond just checking a box. It's really committing to safety. And so I ask everyone on the call, whether you do have a committee or whether you're just starting one, to focus on a couple things. Start small, but start now. Commit to one change in the next month. That could be simply updating a protocol, adding safety to your agenda, or adding a field staff member if you don't have one onto your committee. Look at one meaningful action that you can take in the next 30 days. You don't have to boil all the ocean at once, but visible movement really helps build momentum. If you don't have a committee or you haven't talked about it, bring it up at your next team meeting. Again, if you're not talking about safety, it's not part of your culture. Ask your team, if you're a leader of one of these meetings, a nurses meeting or staff meeting, what would make you feel safer on visits? Or is there anything you've seen or experienced that we should look into? Creating that open door policy really can do a couple things. It can reveal hidden risks, but it can also start building trust with your staff. And then third, start a risk audit. However you can do it, even if it's just the data you have, kind of coming through in the EHR and notes in there. Like I mentioned, you can't fix what you haven't assessed. So, review those incident reports, any high-risk patient flags you might have in your EHR, look at geography, visit type, visit time, use those OSHA risk assessment tools on your own, and use that at intake, and really let that guide you where to start. I'm going to put up a couple of resources here, leave it on here, and you'll get this in the email as well. Some places to start where you can get some great tools, OSHA guidelines, the NIOSH Workplace Violence Toolkit. There's some training modules there on the CDC website. We have a workplace violence safety resources page that we put up and we're continually updating, whether it's around state regulations, some training modules to look at, or just things that are particularly focused on home health care and community-based care, not just hospitals. And we continually update those, so you can go there and get up-to-date information on that as well. But again, the biggest thing to do is just start. And if you are doing something, make sure that you're working your committee and continuing to be proactive versus reactive in that sense. So we'll pause here for questions, but I thank everyone for their time. And if you have anything to put it in the Q&A, or if anything has come in, Denise, happy to take some of those questions.
Well, let's give everyone just a couple of minutes before we sign off. We thank you so much today for coming to us today, Jonas, and presenting this information. If anyone does have any questions, please pop into the Q&A and post those there. I was curious, Jonas, do you have a recommendation on a de-escalation course for folks? Is that something that PalmSafe has to offer, or a resource that's out there that you know about?
We do. We offer those to our customers and folks that aren't customers as well. We work with folks on our team as well as consultant groups to do those, whether it's virtual or in person. On that page I mentioned earlier on our PalmSafe website, there's a couple links to some that you can do or send to your team around safety strategy and de-escalation tools, as well as how to recognize certain environmental kind of things while you're in the home. There's 2 or 3 modules that are on there that you can get to that, again, are free to access as part of that. And that's a really great question and a really great place to start, is what are those key things just to first identify in terms of de-escalating some situations.
Love that. I taught de-escalation for like 7 years in a behavioral health setting. So
Oh, wow.
Definitely very passionate about getting those trainings out there and getting those tools into people's tool belts. I do have one question for you. So this is from a colleague of mine that asked, so what are the most critical proactive measures that can be taken to mitigate the risk of violence in the home, aside from that, maybe that de-escalation course that we just talked about?
What's become increasingly important and really actually becoming increasingly kind of requested or required is that intake assessment. So a lot of times you're doing a safety assessment, at intake, and that's both in the home or asking questions on the phone when you're calling ahead of time, asking, simple things as, are there dogs in the home, other family members we should be aware of that might be there, asking those questions. But 2 is, what are the things that you can identify ahead of time, whether it's in that discharge paperwork, doing a search, a safety search, we call it in our system, that just pulls in key piece information that might not give you everything, but gives you some kind of understanding of, I want to go one click deeper in this, or this may be something that is a little more or less straightforward than just a broken hip, and going in the home and being done. Looking at trends, I mentioned that again, that senior high rise, having some of that feedback of this is a area, or this is a place that we have some issues, or someone feels uncomfortable. All right, let's talk about what are the tools that we can do to make someone feel more comfortable before they go into there, and what strategies we can give to that. But like I said, it really starts at intake. What can you do? And I know that can be time consuming for some, because there's not one, at least right now, standardized kind of search without doing a full background check. But there are some tools out there, and I'm happy to share with folks what some of those things are that can at least give you that first line of defense to say, is there something I need to dig a little bit more into? Or is this something that flags as a potential high risk visit? So we're going to go ahead and enact this check-in protocol, or we're going to go ahead and enact this, whatever it may be, as part of your policy. That's a really great place to start, is again, that proactive side of things, of something to be, have my spidey senses up a little bit more for before I go in somewhere.
That is great. Thank you. There is another one in. Thank you guys for posting your questions. So this one says, for smaller agencies, what are some ways that they are affording devices like Palm? That's always a pushback I get on cost. Penn Medicine has partnered up with Palm, but they're pretty big. So just a question around, I think, cost and around other resources.
Yeah, so like I said, there's a number of things you can do, and specifically, I think it's funny, a lot of times people think that the first thing, and people come to us, is I need a panic button. And that can be costly in terms of an actual device or things, but that's not always something that's needed. That's typically something, the first thing they think of is, we have to get something in someone's hands. But you can utilize other things like the mobile connected app. If you have a smartwatch, it can connect that software to it. And in terms of affordability, I talked earlier about PPE. you're talking pennies a visit for something, like Palm or others that are out there. There's other there. That really, when you think about the cost of what can happen if something goes wrong, for smaller agencies, it can be as simple as just the software side of things, where maybe it's not devices, or maybe it's not the things specifically in a caregiver's hands, but it's that software on the front end that does the safety search things, that communicates, that allows you to log incidents and be able to communicate that out just via text or a team message or things like that. Again, it's starting somewhere and then building that in. And adding to it as you continue to, it's something that a lot of people don't budget for, honestly. It's not
Yeah.
like buying insurance or buying gloves and those things. So it's something you might have to just build into your program.
Right. Well, people see workers' compensation costs go up, that then makes you think about maybe that investment should have been on the front end instead of ending up being on the back end. So it certainly can be costly not to do something.
Right. And like I mentioned before, there's, I believe, at least 10 states that have rebates or savings on workers' comp premiums if you simply have a safety committee that meets certain criteria. Pennsylvania is one that provides up to a 5% rebate by having the committee having communication of how you report incidents and that you're meeting regularly, and you can submit that online and receive a rebate on your workers' comp.
That's incredible. That's awesome. One more question. Can you recommend any best practices for communicating safety risks among the care team?
Yeah, again, so just as simple as if you have a group chat in terms of a texting or logging within an your EHR's part of a care team, or using a software like Palm that can communicate those things out when it comes in the system. If someone is doing kind of that risk review, if you have a software that can easily communicate it out to that care team, it can be kind of pre-programmed. Or if you're doing, like I mentioned, that safety kind of search at intake, putting a note into the EHR that everyone can see, or using a software like a Palm that can push that out via an app or via a text message and a team message. There's some really low cost ways to be able to do that, to give that, like I said, that proactive information out. And again, you're not talking patient and you're not giving a patient name. It's just careful at this address, or something as simple, like I said, aggressive dog, or lights out on the street. You can't park in the driveway, and so take extra care because you're not walking straight in the door. You're having to walk straight, down the street a little bit, and so be careful at night. So those things to just communicate out that help from the environment.
That's good. Thank you for also mentioning the HIPAA aspect of that too, depending on what channel of
Of
communication is being
course.
used. So I'm going to answer just two last questions in here that are more logistical. Someone did ask a question about whether or not we, CHAP, were adding any new safety expectations for home health providers. And I'm going to answer that in saying not that I'm aware of. I did a quick check with a colleague of mine as well, and not that she's aware of either. So I don't know of any that are coming down in that, but that doesn't mean that it isn't possible in the future. As these needs change and our environment changes that we work in. So thank you for that question, Maureen. And then last question was just with regards to the recording and the slides. Yes, if you registered for this, if you were here or unable to attend, you will get a notification when the recording has posted. And there's also a link to the slides up here in the Q&A. It was also in the chat earlier, but I did close that chat as we moved into the presentation. So you can find it at the very bottom of the Q&A with the link there. We also have a channel for our webinars, a YouTube channel for our webinars, so this will get posted there. Being that this is a holiday week and some of my marketing folks are taking an extra day off, that may be next week before that's posted, but we will get that up there on that channel as well. I want to thank all of you for taking the time to be with us today. We really appreciate it. Obviously, that demonstrates that safety is a very valuable thing to you, and that this is something you really want to take some time and make some effort in. So I really appreciate you all. And thank you so much to Jonas for coming to us today and putting this together for you all. So thank you, Jonas. We really appreciate your partnership.
Denise, thank you so much as well, and thanks to CHAP for really, again, promoting this as something that, even though it may not be a policy right now, something that's worth, putting importance to, and it's something, I'm passionate about, and we have nurses on our team as part of the company that are passionate about as well, and I get excited about it. I could answer questions forever, so love just to talk about it because it changes so much, and it's just so unique in that, you don't know what's going on behind door number 1, door number 2, or door number 3 every day. And so I applaud everyone that does this, and our caregivers that are out there every day providing care. And we should do whatever we can, however that is, to make sure they feel safe and supported, because it's something that's just vitally important.
Absolutely. And take note of Jonas's email there. So if you have any more questions, please feel free to reach out to him directly. Have
Thanks
a
so
great
much.
rest of your day.